Yeah, there are some messages.
Good evening everyone and welcome to Grand Rounds in Medicine for the month of February 2025. I would like to welcome the Dean, Vidya Jyoti Senior Professor Weeratunga, Professor Saroj Jayasinghe, Emeritus Professor of Medicine and Patron of the Society, Dr. Nisha Rockwood, Senior Lecturer from the Department of Medical Microbiology and Immunology and Senior Treasurer of the Society. About Grand Rounds. Grand Rounds is one of the longest running projects of the University of Colombo Clinical Society. And what happens is, a final year student presents a case and the case discussion is led by a senior academic from one of the clinical departments. So for today, the case is why is my patient dyspneic? A clinico-pathological exploration. The case will be presented by Ms. Talika from the 2018 A-level batch, and the case discussion will be led by none other than Dr. Praveen Weeratunga, Senior Lecturer from the Department of Clinical Medicine. And I'm sure all of you all here need no introduction to sir. And of course, before I wind down, we will be having a Q&A session at the end. So please do ask. In the live stream, we will be entertaining questions. Thank you, and the stage is yours.
Right, welcome everyone. So, this grand round may be slightly different from what we are discussing. We are going to start off absolutely clinically, right? And then end off slightly different, take you through a process of clinical reasoning to molecular medicine. Right? Then worldwide, we start with a clinical problem and try to identify how to solve that clinical problem through novel molecular mechanisms and research. But we start off absolutely clinically. Now, this is not going to be a two-way process. If you know how I do my lectures, I'm going to wander around with a microphone and ask questions. And the discussion is going to be enriched by your participation. Okay? Right, Tarushi can start.
Good evening everyone. I'm Tarushi and I'll be presenting the case today. So our patient is a 50-year-old welder from Putnam. He was previously evaluated and managed for difficulty in breathing and chronic cough in 21 and currently presenting with an acute worsening of his difficulty in breathing for 1 week duration, also associated with bilateral ankle edema over 5 days. So this all started in February 2021 when he first presented with this progressively worsening dry cough. So this cough persists throughout the day and was not associated with wheezing. He also experienced increased exertional breathlessness which gradually restricted his daily activities, affecting his daily life and his job obviously.
Okay, Tash, can you go to the previous slide? Okay, what I want you to do now is identify the key presentations in this case. So what is the key presentation in this case? Yes, what do you think?
Progressively worsening and exertion.
Right. So there's progressively worsening cough and exertional breathlessness. Okay. This was initially diagnosed in February 2021. Right. Any ideas as to what this might be? Don't worry, you can contribute. Any thoughts? So, because of the cough, yes, this might be some lung problem, isn't it? What sort of lung problem do you think this might be?
It could be something like an interstitial lung disease.
Okay, very good. It might be an interstitial lung disease. Good. Why do you think that? Any reason for it?
Because of the progressively worsening point and that it's dry, contributing a dry cough, as a long-standing dry cough can come with interstitial lung disease, and also increasing exertional breathlessness. All these are progressive.
Yeah. So interstitial lung disease, very good thought. Any other possibilities? So he's basing his diagnosis or differential diagnosis of interstitial lung disease on the fact that the patient has a dry cough and progressive breathlessness. Right. Anything else? You can shout if you like, without the mic. Yeah, so interstitial lung disease, fibrosis are part of the same sort of spectrum of disease. Yeah. Yes, so there is an answer here, COPD. Right. What sort of illness is COPD? Chronic obstructive airways disease. Whereas interstitial lung disease is not an airways disease, it's a parenchymal disease. So, this versus COPD, what features would you find in COPD? Now, because COPD is an obstructive airways problem, you get a slight intermittent nature to the progression. It's not a progression like that, you get a intermittentness to the progression. And also, patient with COPD get chest infections. So it's often this cough is productive, right? And they get infection, fever, and other symptoms. Right. Any other illness that presents with breathlessness, cough, and a lot of sputum? Bronchiectasis. Very good. Okay. So we're dealing with a respiratory disorder, interstitial lung disease possible. What about asthma? Could this be asthma? Any thoughts? People who say, yes, this could be asthma. Or no. You are start up in a, why do we say no? Like what? What is the characteristic history of patient with asthma? Wheezing, chest tightness, very good. And the shortness of breath, the temporalness of the shortness of breath. Is it progressive or intermittent? It's intermittent, very good. Could this be heart failure? Does heart failure cause progressive shortness of breath? It can. What are the other classical features of heart failure? Yes, swelling of the body. What else? Yes, orthopnea and PND. What is PND? Paroxysmal nocturnal dyspnea. Patient lying flat, they get worsening breathlessness. Why do they have that? Because when they lie flat, the venous return to the heart is increased and the pulmonary edema gets worse. Okay, so we have a rough idea as to what is going on here. Is this an ILD? Is this something else? Right? I think as we've started off, this might be an ILD, given the actual history that we are seeing here. Okay,
So with this worsening chronic cough and the acute worsening of exertion of breathlessness, he presented to the Valley Chest Hospital where he was extensively validated in 2021 and diagnosed with a chronic lung condition and started on immunosuppressive therapy. So following this diagnosis, he had to quit his welding job and on the positive side, he stopped smoking.
Right, so this is a welder, very important. Mark that down in your head.
From this initial diagnosis, his symptoms persisted and they steadily progressed despite this treatment. He also experienced multiple infective exacerbation of these symptoms requiring in-hospital treatment. And current presentation, he presented to us with an acute worsening of breathlessness progressing from MMRC grade 2 to grade 3 accompanied by a minimally productive cough for 1 week. This was associated with bilateral ankle swelling for 5 days. By the day of admission, his breathlessness has gone so worse that he couldn't get out of the bed and he produced small amounts of whitish non-blood-stained sputum with the cough. Although he did not have fever, he complained of malaise and arthritis.
Okay, now what is causing the current presentation, do you think? So we are suspecting a lung problem, we are suspecting a parenchymal problem, right? We think it might be ILD, as one of you mentioned, right? Just given the progressive nature of the symptoms and the dry cough, right? And what is causing the current presentation? Shout. Back one. What is causing the current presentation? Yes? Cor pulmonale, what does that mean? What is cor pulmonale? So there is pulmonary hypertension secondary to lung disease. What of the symptoms here does that explain? What? Ankle edema. Why do they get ankle edema? Because cor pulmonale causes right heart failure. But the other presentation of breathlessness, shortness of breath, productive cough might be due to an infection, isn't it? Right. Okay.
So throughout this chronic illness, he has not experienced symptoms of heart failure such as orthopnea, paroxysmal nocturnal dyspnea, and has no history of cardiac disease. Also, he has no clinical features suggestive of connective tissue disorder such as rheumatoid arthritis or scleroderma. Additionally, he has no history of deep vein thrombosis, pulmonary embolism, or pulmonary tuberculosis. As I said, he is a chronic smoker since 25 years of age with a total back years of 2 and stopped smoking since the diagnosis. He has a significant occupational exposure history because he is a welder. He is exposed to toxic metal fumes and he gives a history of working in construction sites. There is possible exposure to silica and asbestos. He does not give a history of exposure to birds or mold and no family history of chronic lung diseases or malignancies.
Right. Can we pause there? What is this? What has this welding got to do with this story? Could it be related? Could the welding be related? Right. General knowledge. What is in the welding fumes? What are the things that are there? What? Welding fumes, what does that contain? Sorry? Iron oxide, very good. Anything else? Carbon particles, iron oxide, various sorts of metal fumes, metal substances. Professor Saroj, would you like to answer? Lead, yes, right, lead. Lots of toxic metal gases, right, easily can damage your lungs. Right. So, this again builds weight to our differential of a lung problem, maybe a parenchymal problem, maybe an airways problem also secondary to all of these toxic fumes that he is inhaling over a period of time. Okay? Yeah.
He was also recently diagnosed with type 2 diabetes mellitus and currently on oral hypoglycemic drugs with good compliance. But he has no micro or macrovascular complication and also has no clinical symptoms suggestive of them. He has not undergone any surgeries and has no known allergies. With regard to his family history, his sister was diagnosed with a similar chronic lung condition and died at the age of 45 years, but he is not exactly aware of the condition. As I said, he is a 50-year-old welder from Putlam. He is currently living with his 20-year-old younger son who works as a chef. He and his wife separated 10 years ago and the elder son is married and living with his family separately. He worked as a welder before and currently unemployed, so the younger son takes care of the patient and has been assisting with his activities of day-to-day life during the last couple of days. Otherwise, he has been independent on his activities of daily life. He is a chronic smoker and also consumes alcohol occasionally. He is currently financially dependent on the younger son who is also missing work due to the illness, and he is currently deeply worried about his condition and is worried about his son because he thinks he is being a burden to his 20-year-old son.
Right. Before we go to the examination, can you see the social impact of this illness? Right? The social and economic impact of this illness. Now in clinical practice, we often forget this. Right? We often want to figure out, okay, what's going on in him? What is the diagnosis? How do we treat this? But beyond that diagnosis, there's often unique socio-economic constraints that the patient has. And a typical example is this patient. He cannot work. He's dependent on his family for lots of things, including finances. Right? So here is a patient with a chronic respiratory problem. Compounding that problem is a series of social and economic constraints. Okay?
On examination,
Now, examination often helps us to now narrow down our diagnosis and confirm our diagnosis, right? So guys, can you tell us what you found in the general examination?
In the general examination, he was AFib at the time of the examination. He was moderately built with a BMI of 22 kg per square meter. He had plethoric conjunctivitis. He had stage 4 clubbing in bilateral fingers and toes. Also, he had bilateral pitting ankle edema, but no signs of non-dependent edema. He did not have enlarged lymph nodes or joint deformities, skin thickening or body rash.
Right, can we now ask, now what do we think? So, one of your colleagues mentioned interstitial lung disease as a possible diagnosis. Is there anything in this examination that supports that theory? What supports that?
Stage 4 problem.
Yes, clubbing, is that a feature of interstitial lung disease? Does that happen? Now, we thought of COPD also. Does clubbing occur in COPD? No, is the answer. Unless they have some malignancy in the lung on top of the COPD. Right. Does bronchiectasis cause COPD? Yes. But the typical story of bronchiectasis is that lots of sputum product. This patient had infective exacerbations also. So let's keep that on the side, right? Heart failure, does that cause clubbing? Generally, no. And why is there pitting ankle edema? One of you mentioned the possibility of cor pulmonale. Very good. So there are signs in the examination to support your diagnosis of a possible interstitial lung disease with the clubbing. Yeah.
In the examination of the respiratory system, he was in respiratory distress. He had several signs of respiratory distress such as subcostal and intercostal recession, and he was using accessory muscles of inspiration. He had a respiratory rate of 20 cycles per minute. His oxygen saturation on room air was 82%. His trachea was in the midline. His chest was normal with no scars or chest wall deformities. Bilateral chest expansion was symmetrical but reduced in bilateral lower zones. Vocal fremitives and vocal resonance equal bilaterally with impaired percussion note again in bilateral lung bases. There was vesicular breathing pattern, but the intensity again reduced in the lung bases. Significantly, he had diffuse and inspiratory fine crepitation in all three lung zones bilaterally.
Right. Any comments about the respiratory exam? Are we down the right track or are we going down the wrong track? Respiratory findings. Can somebody explain that to us?
The findings are along the line of what we are thinking, because especially on auscultation there are inspiratory fine press, so the situations where we get that is heart failure or COPD, ILD.
Yeah.
So given the other findings on general examination such as clubbing and impact percussion note and reduced entry, it is suggestive of
Suggestive. Why is there dullness to percussion in the lung bases? Why do you think there's dullness to percussion in the lung bases? Any idea? Yeah? In the context of an ILD? Fibrosis. Yes. Right. What happens to the vocal fremitus and resonance in fibrosis? Generally, increases. This patient, it was normal, but if there is quite dense fibrosis, it increases. Yes. Good. So we seem to be down the right track. Lots of findings in the examination are supporting what then this might be an ILD. Yeah.
Moving on to the cardiovascular system, he was hemodynamically stable with a pulse rate of 88 beats per minute, which was regular and of good volume. His jugular venous pressure was elevated. His blood pressure was 110/70 millimeters. In precordial examination, there was a parasternal heave with a loud and palpable beat. The rest of the system examination was normal.
Can somebody comment on the precordial examination findings? Would you like to? Mic close to your mouth. Yeah.
Due to the pulmonary hypertension.
Yes. Why do you get parasternal heave?
Due to the right ventricular hypertension.
Excellent. Due to right ventricular hypertrophy. And what about the palpable second heart sound? Again, features of pulmonary hypertension. So one of you mentioned this patient might have ILD, a chronic lung disease, which causes pulmonary hypertension. How does a chronic lung disease cause pulmonary hypertension? Yeah? Yeah, hypoxic vasoconstriction of the pulmonary arteries. That is the reason. Yes. Very good. Okay, it's fine. Okay. So this is a summary. If you have been listening to the presentation, you don't need to read this anymore. Next. So what is the, can somebody give me the complete diagnosis in this patient? Interstitial lung disease complicated with pulmonary hypertension leading to right heart failure. And can you add a little bit more to that diagnosis now? Remember, when somebody asks you for a diagnosis, it is not only the condition that the patient has. You can also mention the complications as well as maybe the what? Etiology. So can you add a little bit more to that? So interstitial lung disease, pulmonary hypertension, right heart failure due to what? Most likely occupational exposure to welding fumes. That might be the most likely complete diagnosis. And remember, on top of all of that, there are lots of socio-economic problems as well which we need to address. Right. Okay, thank you guys. So I'll take it from here. So now you can see, using a very simple clinical approach, by breaking down the history and the examination into symptoms and signs, we are able to make a very accurate diagnosis, right? Just through clinical symptoms and signs. We have not even done an X-ray in this patient up to this point. Okay. Now, our diagnosis is ILD, pulmonary hypertension, right heart failure, second to welding fumes. Now what we need to do is, we need to try to prove this, confirm this. So how do you prove a diagnosis of ILD? As you can see, history and clinical examination are paramount in the diagnosis of ILD. The history of progressive dyspnea, dry cough, right? Maybe multiple exacerbations, clubbing, end inspiratory crackles on auscultation, all support a diagnosis of ILD. What do you do next? Simple. What sort of respiratory disease is ILD? Is it an obstructive disease or a restrictive disease? Right. Now we need to prove that next, that the lungs are restricted in their inflation. How do we prove this? What is the next investigation that you like to do now? Yes? A lung function test. Specifically, what lung function test would you like to do? Spirometry. What do you mean by that? Yeah, so the FEV1 FVC ratio. What happens to that in a restrictive lung disease and interstitial lung disease? Will the ratio change? No, it won't. Why won't it change? Because the FEV1 and the FVC are both reduced. So the ratio will remain the same. What other lung function tests would you like to do? Now remember, in interstitial lung disease, the alveolar capillary membrane is thickened. There is a lot of fibrosis around the alveolar capillary membrane. So what else might support your diagnosis of ILD? What is that? How is that going to help? Very good. So if you measure the diffusion of a gas, carbon monoxide, across the alveolar capillary membrane, the diffusion is reduced. Why is it reduced? Because of the thickness, fibrosis around the alveolar capillary membrane. So what will you ask for? You ask for FEV1, FVC, which will be normal, and a DLCO, which will be reduced. Right. So that is one element of your diagnosis. History examination, lung function test. What else would you like to do now? To prove that there is ILD, one of the definitive tests, radiology. X-ray. Better would be to do what? A high resolution CT scan. And there are various patterns of pathology, abnormality associated that you might be able to see, which I will show you in a minute. Right, so as you can see, you have your history examination, initial assessment and CT scan. And as you can see, something that we do very poorly in Sri Lanka is a multidisciplinary team assessment. Right? So having worked in one of the ILD centers overseas, these sorts of patients, everybody sits down together. You have the respiratory physician, the radiologist, pathologist, everybody sitting on the same table and making the diagnosis. So these are the elements associated with the diagnosis of ILD. Don't worry about antibodies for the moment, we'll talk about that later. Right. Okay, now if we just move this out of the way. Right. What is causing this patient's ILD most likely? What is the most likely cause? Occupational exposure to welding fumes. But you might also for other causes depending on the clinical scenario. It is not essential here because there is an obvious occupational exposure, but in certain clinical cases you might need to look for autoimmunity. You might need to look for something called hypersensitivity pneumonitis, which probably is part of the pathological process of welding fumes, right? And then also there are various drug-induced ILDs around, right? Name 3 drugs that can cause ILD. Methotrexate, amiodarone, nitrofurantoin. Very good. Right. So this is how you approach a patient with ILD. Now, this is where it goes a little bit beyond undergraduate level, but that's fine. We don't want to restrict your thought and thinking. Now, in ILD, the radiology and the pathology plays a massive role in understanding the disease. Right? Now you have diagnosed ILD. No problem. Now what you need to do is try to understand the pathophysiological mechanisms of it, treat it better. Due to this, there are various clinico-pathological entities of ILD. The clinico-pathology, that's why the title says Clinical and Pathological Exploration. So once you diagnose ILD, you look at the radiological pattern and sometimes the lung biopsy pattern. And using these features, you will be able to divide it into one of these 5 groups. Okay? Usual interstitial pneumonia, non-specific interstitial pneumonia, organizing pneumonia, hypersensitivity pneumonitis. I'll just take 2 of these as an example. The UIP pattern is featured by honeycombing. That's one of the classical features on the CT scan. If you do a biopsy, you will find fibroblast foci. And the fibrosis is around the edge of the lungs, surrounding the lungs. Compared to that, non-specific interstitial pneumonia is more ground glass opacification. Whitishness scattered across the lungs, right? So you can see that these entities are different. Hence the way you treat them are also different. Okay? Right. So what is your workflow now? You diagnose the ILD and then you look at the radiological, pathological type of ILD. Right. Okay. So in order to diagnose the radiopathological type of ILD, CT scan, occasionally biopsy is indicated. Okay? Right. Now how do you manage these patients with ILD? Now in our patient who is exposed to welding fumes, right, had a CT scan evidence of ILD. Now what are you going to do in this patient's management? Simple things first. Do you want to stop him from getting further lung injury? Yes. So what are you going to do with that? Stop the exposure. Okay. Right. And then, what else? We want to stop this process from progressing, isn't it? So how can we do that? One thing is, most of these processes are immune mediated processes, right? So what can you give this patient? Immunosuppression medication. There is fibrosis going on. So what medication can you give to prevent fibrosis from progressing? Anti-fibrotic medication. Now, some of these drugs we do use in Sri Lanka, perfenidone and nintedanib. Both are anti-fibrotic agents that used to prevent the disease from progressing. Right. And trials that show benefit us. Now, in this patient, we're thinking of welding-associated ILD. What happens in welding-associated ILD is, based on animal studies as well as limited human studies, these toxic fume particles are phagocytosed by macrophages. What are macrophages? These fellows are the ones that clear off all the toxic stuff in your lungs. One of their functions. However, because of these toxic fumes being engulfed by the macrophages, these fellows accumulate in the interstitial spaces and in the airways and get activated. When they get activated, they start producing lots of immunologically active molecules, cytokines. And this causes fibrosis. Right? So this is the pathogenesis of in this patient. Right, now the last part of this discussion. Now this is where you as the future come in, right? Now, even though some of this is quite cutting edge that I am going to tell you now, it's not beyond us, right? So let's see how you think. Now one main problem in ILD, it's a nasty disease. I would not wish to get it. Because even though you use immunosuppressants, even though you use antifibrotics, the disease progresses. Can you cure it? You cannot cure it. It progresses, right? And what happens when you give lots of immunosuppressants to a patient? What is the side effect of that? Infections. Is this patient particularly prone to get infections? Why? Yes, loud. Because of the patient has damaged lungs plus another comorbidity that was recently diagnosed, diabetes. So what happens now? You create a vicious cycle. You give immunosuppression, that triggers off more infection and that causes more fibrosis. So you're in a very sticky situation, right? To treat this patient, we have to control the macrophages, control the immune system, stop the fibrosis from progressing. But the problem is when you give immunosuppression, especially in a country like Sri Lanka, lots of respiratory pathogens floating around, TB, fungus everywhere, they get infected again. That's what's happened to this patient. Tarushi was talking about recurrent chest infection. Why? Because of the immunosuppression. So now you're in a horrible vicious cycle. So therefore, don't you think we need to change our approach to managing this disease? Why don't we look at the cause of the disease and try to control the cause of the disease or reverse the cause of the disease? Then we might stand a chance. Okay? So you understand the limitations of what we have at the moment. Now let's think beyond that. And let's use idiopathic pulmonary fibrosis, which are the subtypes of ILD, as an example. Right. Now, over decades of research, now we know that IPF is an epithelial driven disease. Now tell me, what are the cells you find in the alveolar epithelium? There are only two major cells you find in the alveoli. What are they? Type 1 alveolar epithelial cells and type 2 alveolar epithelial cells. Of those two, what does a type 1 alveolar epithelial cell do? Gas exchange. What does a type 2 alveolar epithelial cell do? Basic sciences students, if they are there, you can now shout. Yes? Surfactant production. Yes. Anything else? Very good. Regeneration. The type 2 alveolar epithelial cell is the stem cell in the lung. If there is any damage to a type 1 epithelial cell, who forms the type 1 epithelial cell? The type 2, through a regenerative stem cell process. Right. So what do we know about IPF? We know that there is repetitive injury to the alveolar epithelium and there is a genetic susceptibility in some patients. Right? We have found genetically that in IPF patients the telomere is short. Right. Now with Professor Bajra is an idea, you should know what a telomere is. Yes. So what is a telomere? What do you mean when a cell has a short telomere? What is the? It senesces faster. So what happens? These cells are very old, right? And they die off quickly. So this on top of genetic susceptibility. Shorter telomeres causes this loss of type 1 alveolar epithelial cells. Now if your lung was normal, what should it do? It should use the type 2 alveolar epithelial cells, stem cells and regenerate. But now we know that what is the driver of IPF? It is abnormal alveolar regeneration. The alveolar epithelial cells, type 1s, don't give rise to, type 2s, don't give rise to normal type 1s. That is the problem. So even abnormal alveolar regeneration and these abnormally regenerating alveolar cells secrete various stuff, cytokines and various things, which promote fibrosis. And also another important consequence is when the alveolar AT2 converts into an abnormal AT1, what happens is they're not flat. You can't gas exchange across them. The cells that form are like airway cells. Do you get gas diffusion across your trachea? No. So the cells that form from the stem cells are not normal AT1s. They are abnormal bronchial-like cells which cannot participate in gas exchange. So this is the problem. The abnormal regenerating alveoli trigger off a series of mechanisms that cause fibrosis, number one. Number two, it generates cells that cannot participate in gas exchange. So now can you understand why your patient might be dyspnoeic, a patient with ILD, they can't have gas exchange. That's fibrosis. There are bronchial cells that oxygen doesn't travel across. So this is where the money is. The problem is abnormal alveolar regeneration. If you can hit that, then you will treat the cause of most of your ILDs. In this patient, the building fumes must be the culprit causing the abnormal death of alveolar epithelial cells and the subsequent regeneration. So can you see how we are now thinking, can we address this problem rather than address the downstream problem of fibrosis? Right. Now this is an example of what a lung. Can you see all of these things here? Yeah. So these are honeycombs. Honeycombs are areas of cells which are bronchial-like cells. Does gas exchange occur across any of these? No. So it's a typical picture of ILD. Can you see the lung in the healthy person here? Thin air spaces, easy gas exchange. This is IPF. It's full of muck. All of these are immune cells and abnormally regenerating alveolar epithelial cells. Do you see the problem? And do you see also whole loads of immune cells as well? So now if you want to target this, what might be happening here? The injury might be bringing a lot of immune cells which are propagating this abnormal regeneration. Which are quite, let's see the stark difference. Whole loads of immune cells are there. So maybe there is a crosstalk between the regenerating alveolar epithelium and the immune cells. So can we target that is the question. Right. Can you see these areas here? These. That's all abnormal alveolar regeneration cells, which are base markers in which you look for these, but here none of these participate in gas 16 in these areas. Right. So, we come to the final question of the day then. We now know that in IPF, current therapies are not good enough. What are we now trying to do? We are trying to address the abnormal alveolar regenerating focus, right? That's what we are trying to address. We are trying to prevent them from converting into bronchial-like cells which cannot participate in gas exchange. We are also trying to stop them from triggering off the fibrosis process where there are lots of cytokines. And we think that immune cells might be talking to these cells. So, what is happening in these areas of abnormal regeneration and fibrosis? Can we identify what cells are involved and mechanisms that they are talking to one another? Right? Okay. Now, to identify if somebody is talking to another cell, what is one of the major prerequisites? Now, for example, you are here and there is some other fellow there. What is the chance of you communicating? Almost zero. What is the chance of her communicating with someone next to her? Is high. Right? So, in order to identify these crosstalk mechanisms, we have to identify what cell is next to another cell. Right? That is an important thing. Right? So, how do we do that? Right. So, this is cutting edge stuff which you should know about. Now, there are techniques now which are called spatial techniques, right? Spatial techniques means that you can go down, take a piece of lung out of the patient and go down to the single cell level. You can go down to the type 2 alveolar epithelial cell. You can go down to the immune cell and identify what is its RNA. What RNA does that cell contain? What is its epigenetic characteristic? Epigenetic characteristics are at the chromatin level. You can identify that. You can thirdly identify what proteins are these cells producing, right? What proteins are these cells producing, right? Number 4, you can identify what metabolic pathways are being used by these cells. There are techniques for all of this. Just take a lung tissue of these techniques. If you are interested, you can meet me later and I'll give more explanation, but that is simply what these techniques do. So, on a lung tissue, so now what can we do? We can go back to this. We can use one of these techniques in these areas and figure out what are the cells here? What is their RNA? What is their chromatin accessibility? What is their protein production? What is their metabolic pathway? You get a massive load of information now. Also, using complicated mathematics like this, right? Even I don't understand. Right? You can figure out what cells are next to another. Exactly like a safari park, and you can figure out where the lion is, who is next to the lion, who is next to the zebra, who is next to the giraffe. So can you see the amount of information we are getting out of this now? We are getting, so let's keep all of that, we are getting what cells are there, what is their RNA, protein, epigenetic, metabolic signature, how close are they to one another, and how are they talking to each other. Right. So what do we do then? We, at the end of all of those mathematics, this, right? What does this picture say? if you look at IPF at various stages, these networks represent what cell is next to another. What I've highlighted in green are cells in the aberrant alveolar regeneration areas in early, advanced disease and intermediate disease, right? And all of this is by the Max equations that I mentioned, okay? Right. Now, can you pick out the common thing in this? So this green area is where the alveolar regeneration is occurring. That is where they are interested in. That is where the problem is. Can you see, so this is some work I was involved in also. Can you see that consistently there is a subset of macrophage that is close to that niche, this area. Right. So what do we think now? These abnormally regenerating alveolar epithelial cells and this macrophage is probably what? Talking to one another. And that crosstalk might be promoting the disease. The final step is you use various bioinformatic pathways to figure out what this crosstalk might be. What is the mechanism of this crosstalk? And using these bioinformatic mechanisms, what we found are 3 important pathways that are probably related. So the macrophage talking to the abnormal niche of cells using pathways like syndican, fibronectin and integrin. And using those mechanisms, we can generate a potential pathophysiological model as to what is going on in these regions, right? So now what is the next step you would like to do? Try to block some of these pathways and see if anything changes, right? Because your main hypothesis or question is abnormal regenerating foci, they are talking to macrophages and they are promoting fibrosis. So if you block this, does it change? The answer is probably about 10 years, not 10 years, 5 years beyond us at the moment. Right. So, that last part obviously we are going to ask you the long case. Right. But can you see, taking the disease of IPF as an example, we started off bare basics clinical. Because if you don't do your clinical, you can never diagnose it. What did we do next? We used investigations to confirm that diagnosis. This is what we do all the time in Sri Lanka. Clinical, investigation, diagnosis. Then what do? We treat the patient. And then we try saying, okay, this patient is not getting better. That's where we stop. Not only us, most parts of the world. But now I've shown you, you don't need to stop there. You can go one step further. Think. One of the bad things we do in medical school is block your thinking. You don't need to be like that. Think. If the current therapies are working, can we think of this in a different light? Can we go to the root of the problem? In IPF, what is the root of the problem? It is the abnormally regenerating alveolar epithelium secondary to injury. In this case, the welding fields. Right. Can we address that? We saw lots of immune cells in the lung in those regions. Is there a crosstalk between these cells? And is that promoting fibrosis? Then using posh methods that maybe in my lifetime I will never see in Sri Lanka but are available in other parts of the world, you can still map out what cells are there, what is using mathematics, which you don't need a machine for, you need your brain for. Map out what cell is next to another and how is it talking to one another. Identifying that signal can help you block it, and there you have the answer. So starting from basic sciences, clinical, back to basic sciences, you can sort out the disease. That is a cycle. Right? Okay. Any questions? I thought it was just boring to discuss a long case in this forum because I want you to open up your minds to what is around you rather than just, okay, make a Praveen sir, long case එක අහන ප්‍රශ්නේ මේකයි. How do you diagnose ILD? Right? That's a useless exercise. This forum we will use to expand your knowledge and thought. And maybe you will discover something one day. Any questions? Wait.
So, in the different kinds of interstitial lung diseases, is the long-term prognosis different or is it one?
Right. The question is, in different types of interstitial lung disease, what about the long-term prognosis? They are not the same for each. The UI, so remember why we classify it into UIP, NSIP and so on. That gives an idea of prognosis. UIP is a relentlessly progressing disease, right? Within 5 years you are flat, 10 years max, despite treating them with antifibrotics. Certain types of ILD have better prognosis. For example, there is a disease called sarcoidosis, which is ILD. We don't see that a lot in Sri Lanka, but quite a lot in the West. That responds excellently to steroids. It is most of it, right? So it varies. ILD due to IPF, UIP, horrible prognosis. And that's why they are looking at that as an example, trying to figure out what to do.
No, in this patient, there was a significant family history of chronic lung disease also. Like,
Yeah.
does that cause us to think of other lines and then?
So, can ILD be familial? Think. No. ILD be familial? Huh? Connective tissue disorders are not necessarily familial in the Mendelian sense, but there might be some HLA sort of susceptibility there. Most of the time, ILD is a complex pathogenesis. There are genetic factors that are not necessarily Mendelian inherited, plus environmental factors. So somebody, I might have a genetic risk, but I don't go around welding, right? If I went around welding, I might get it because my genetic susceptibility is there. My telomeres might be short, who knows, right? So unless you're exposed to the trigger, the injury will not take place in that abnormal manner.
So maybe my understanding of this is wrong, but like this crosstalk or whatever, it's sort of the body's attempt to kind of get over this stressor, right?
Yeah.
So if we were to block that, would the person perish or injury?
Excellent question. This is your body trying to control it. But the problem in IPF is it's excessive and it's abnormal. If your body was doing a good job, the moment you lose your alveolar type 1 cells, it should form them out of 82 cells, job done, chapter closed. But the problem is because of some genetic factor, probably, it's not regenerating the normal, it's abnormal regeneration, right? So that's what we're trying to stop. But yes, as a side effect of some of these therapies, normal regeneration might also be affected. That's right. So that's why we test these all in the lab before testing them on humans.
So, these novel therapies, is it only going to stop progression of the disease or would it be able to recover some lung function?
Yeah, so if these drugs that target alveolar regeneration work, that would actually, because you're addressing the root cause of the problem, you might be able to regress the disease.
So if there's already some fibrosis, that might...
Well, you may cycle, it's a progressive cycle, so you might have to stem the cycle and get it a little bit better, right? And as you say, it depends on the stage of the disease also if you start this medication or not. If you start medication on somebody with advanced disease, it may not work. But if you pick them early and start it early, then it might actually help to regress some of the pathology.
Excellent defense of the case. I was just wondering if the primary pathology is in the type 2 cells. We'll get to it by doing single cell of the type 2 and cell and then you'll find it.
Yeah. So what we're actually doing at the moment is the question, if the problem the type 2 alveolar epithelial cell, the focus on on that, and is there anything wrong with that? So, how you study this is in something called alveolar organoid, right? So, what is that? So, remember, 20 years ago, we do mouse experiments. Take a mouse and give them various things and see what happens. In lung, people use bleomycin. Have you heard of bleomycin? Now, the mouse is not a human, right? It doesn't reflect the human. What we do now is take the algal epithelial cells out of the patient and culture the and looking at the transcriptomic or whatever characteristics of the 82 cells there are some interesting things that are found which are difficult to disclose.
That's why he said there's money in it. You know, he has signed an NDA with us. I was going to ask you what secret. Why did you say there's money in it?
Drug companies. I have not signed a non-disclosure drug company, but it's work in progress. We are working on this alveolar organoid and looking at what exactly happens in the epithelial cell at the moment. Yeah. So, mechanisms are involved.
I say that sign a contract with a drug company in a bad way. It's going to be good because once he gets a patent, he's going to give 50% of that to the university. So, yeah, one patent for $1 billion drug, and we get $500 million. And if you building on the other side, that's what I do. I wish you good luck.
And along those lines, the world is open to you. We have plenty of talent here, but we are restricted in accessibility to these work. Some of our brains there, we attacked some of these problems a long time ago. So, in Sri Lanka, I know we have clinical needs, but then maybe we want to go into one of these areas, and that's why it's not a closed area, it's not unachievable.
These molecular pathways we talked about towards the end, are they unique to the disease or are they unique to each patient such that we have to tailor the treatment to the
Very
patient?
good. So the question is, are these pathways common or are these pathways unique? The answer to that is really not very clear. And this is a commercialized medicine. So in the future, what will happen is, you get a patient with your clinic, diagnose the ID, then go off the lung biopsy, do all these tests, identify the pathways, and give them selectively block that patient. That's how I see it. And it very well might be that these pathways are only in a subset of patients. So this is where personalized medicine comes. It's a very, very good question. Yes.
Thanks, Praveen, and brilliant presentation as usual, and for inspiring the next generation. I'm going to talk of something completely different because we used to talk about pneumoconiosis. And as medical students, we visited Bogota graphite mine. We have 3 mines which give us graphite, and by the way, it's very high quality graphite. Some of it is being converted to graphene, and all mobile phones are have graphene. Anyway, what's the pathophysiology of fibrosis which we used to see in these workers? Because a lot of them used to die of pulmonary fibrosis, and I think some of them developed lung cancers also. They used to die. One of the key people who described pulmonary fibrosis is late Dr. C.G. Brewer. He has described the pneumoconiosis. He does so what's it called? Graphite.
the mechanisms also in that, right? But again, these are problems of global equity in health research, because these problems are no longer prevalent, nobody is studying them. So we don't know. What I think is there might be a mixture of mechanisms of a hypersensitivity reaction to the inhaled graphite, as well as due to the injury on the alveolar epithelium, something very similar to what I described as an abnormal fibroproliferative response and regeneration. But unfortunately, nobody is studying this anymore.
Because that's some area we can work on, because we have got a captive, and 2 of the graphite mines are state-owned. One graphite mine, 80% stake is the Germans. But I think
some of these methods can be applied to local problems quite easily.
We were talking about how the patient had recurrent chest infection, right? So is it only because of use of immunosuppressants or another mechanism by which we can cause infections?
Right. So recurrent infections, one of the main reasons is immunosuppression. Also, when the lung is damaged, lots of bacteria like to go and stick around in the lung. One famous fellow is Pseudomonas. They hang around there idling away, and when there is a little bit of a drip in somebody's immunity, they start causing an infection. So it's a combination of immunosuppression, bacterial colonization on pre-existing lung injury that causes the infection. And remember, when the lung is abnormal, now we don't get infections readily because a lung has cilia, takes out all the muck, right, clears organisms. In a patient with a lung like that you saw, do you think the cilia are working, pushing stuff out? No. So the normal defense immunity of the lung is also not working. So that's another reason why they get lots of infections. And fungal, yes, mycetoma is also a very nasty infection, the aspergillus, that occurs in patients with lung disease.
So you mentioned that certain individuals have a genetic predisposition towards interstitial lung disease. I was wondering if that genetic predisposition also extends to drug-induced interstitial lung disease?
Probably yes. There are certain ones that have been linked. Yes.
For example, if a certain family member were affected by methotrexate, then are you more susceptible essentially?
Not specifically for methotrexate, but there are certain instances where that is the case.
Right. And also pertaining to drug-induced, is there a reversibility to drug-induced interstitial lung disease?
So again depends on the stage you catch it at. If it's very early, you stop the drug immediately, calm down the immune system with something, it goes away. But if it carries on undetected, then you go to the point of no return, and that's it. So cirrhosis, we do liver transplant. The question is, can you do lung transplant? Yes. But lung transplant is not an easy business. Even in the UK, only 3 centers do it well, right? It's a very, very difficult business. It's not, putting a lung into you is relatively simple, but then managing the patient before and after is a nightmare, right? And especially in a country like this with lots of infections around, it's an absolute disaster, right? So it's a very complicated process, but it is theoretically possible, and people do it in other countries. I think we need one lung transplant. Yeah. So the question is, how do you manage the pulmonary hypertension in this patient? The therapies for pulmonary hypertension, what is the problem? One of you mentioned that it is hypoxia-induced vasoconstriction. So what is the natural drug that you would like to give them with? Vasodilators. Examples? Sildenafil. There are others that work on the phosphodiesterase system like bosentan and things like that. Unfortunately, in patients, so for that to work, pulmonary vasoconstriction should be reversible. In patients with ILD, a lot of the time, the pulmonary vasoconstriction is irreversible, because all the blood vessels are also trapped by the fibrous tissue, so they can't get bigger. So the response rate to sildenafil and other vasodilators is less. In contrast, there is another condition called primary pulmonary hypertension. They have a beautiful vasodilator response. here the effectiveness of therapies is lower. Because the vessels are trapped by the fibrous tissue and the irreversibility of vasoconstriction. Yeah, same here. So here, fibrosis is a beautiful nidus for cancer formation. Anyway, abnormal regeneration, if that occurs without a check, what happens? They get neoplasia, right? This is why we teach you basic sciences and pathology. So again, inpatient diet, they have a high risk of lung cancer. Yes. And when you get toxic damage to the lungs, what happens? You get various genetic abnormalities that can predispose to lung cancer.
Any possibilities of getting exacerbation without infection like that?
Yes, the disease can progress rapidly in some people. Those are called rapid progressors, very difficult to manage, often die. In my lifetime, I tried to set up center here. No, the problem is this, it's not the lack of facilities. In most of the countries around the world, even in the UK, there is only, so some of the machines I showed you, there are only 4 machines in the whole of the UK, right? What people do is collaborate. You send your samples and you get stuff done. You don't need to buy a machine and place it physically here. So the world of research is now headed in the direction of collaboration. Sample sharing, data sharing, knowledge sharing. Right? What you need is essentially, a lab technician can do this experiment. But what you need is a brain to interpret the findings of that experiment and think. That you don't need £1 million to do. You just need your brain.
Actually, any experiment you want, there are companies who will do it for a fee. So you don't have to spend any money trying to set up a lab here for anything. There are certain things that we do, which only we do once during an entire lifetime. So for that, you don't need to set up a lab. There are companies which will, just have to send what your sample is, and they will do the test, and then they'll give you the result, and then you go on. So that's how the world is moving now.
Also, you don't need a person to do it. Sometimes mostly done by robots.
Yeah. It's what you do with the data and all of that matters, rather than where you get it done, what you do.
And some of these complex pathways, AI is used now to dissect, because human brain can't handle most of these pathways and see what's the relevance of that. There are millions of pathways that come up. How do you know what's relevant? So people are now using AI to sort of filter up and sort of look at the more targetable pathways. And there are lots of things where you can actually model what happens to a pathway on a computer. You can say, okay, block this receptor, what is the outcome of that? You don't need to do an experiment. It's all done on a computer. Okay then, I mean.
This is a question from the students. He's got heart failure, right heart failure. What's the place of diuretics? What's the dose? What are the dangers?
Yeah. What diuretics? Recently passed out doctors right now. Yes, Abraham. Right, so we can withdraw your first class. So what is the role of diuretics in this patient, Manu? You can sort out Anurag later on and kill her if you want to.
I suppose there will be symptomatic benefit.
Yes.
But not much of a survival benefit.
Very good. Yeah.
So we can give it to somebody.
Yeah. what might be compounding the edema in this patient apart from right heart failure, in addition to right heart failure? Can there be some liver problem also?
Yes, due to the right heart failure, there can be congestive hypertrophy, so that may contribute to the edema by reducing the protein production.
Very good. These are the first arguments. Right. Okay then. Thank you.
Thank you, sir. And now I'd like to invite the Dean of the Faculty of Medicine, University of Colombo, Vidyajyoti Senior Professor Vajira H.W. Disanaika, to speak a few words to the audience.
I came here to see whether I can pass the final exam. I think I can make it still after doing medicine 25, I mean, almost 30 years ago now. But it was fascinating, going through that case with Praveen. I always say, like, you will learn, you will learn the most, and you will always enjoy this, young lecturer, because I always, think about my time in medical faculty, and one lecture which really made an impression on me was the lecture on nephrotic syndrome given by Ruchika Lanaro. I can still close my eyes and see him, draw this thing on, in this Block C lecture hall, which we still call the new lecture hall after 50 years. So I think, to me, sitting there after a long time listening to lecture, it brought back memories. I think, but really, it also, what I want to actually get to is that bit, the clinico-pathological exploration, because we can all learn the clinical stuff, and then, the problem is we don't do that. We don't get down to the bottom of the pathophysiology and go with a mind thinking we have to cure this disease. And we always tell our patients, okay, this is it, I think that's the end of it. But I think we all have to also change our mindset that we are going to go and cure illnesses. My kind of exposure to that was many years ago. In 2007, I had the opportunity to go and work at the National Institutes of Health in USA, in Bethesda, Maryland. There's a place called the Clinical Center of the National Institutes of Health. That is where Fauci works, the famous Fauci which Donald Trump is going after. There are 1,400 beds in that hospital. Every patient in the hospital is a patient on a clinical trial. So I was used to the British way of, counseling and sending the genetic patients home. I went to Bethesda, and every patient there, the Americans somehow want to cure that patient. So they're trying, every patient who in UK, we would be just, those days, counseling and sending home. And patients also want a cure. So a completely different mindset. And that is why all the inventions, all the cures, and everything are coming from that part of the world. Unfortunately, we have become very consumers. We are not looking, okay, if a drug doesn't cure, drug coming from Western country doesn't cure, can we, come up with a cure? Can we do that exploration? So we can, and we should be aiming for that. And so if I were to, like at my stage in my career, want to, set a target for myself, the target would be to find a cure for one illness at least. So because that would be a game changer for this country, because that's what we haven't achieved. Let's get a cure for some condition, and we must aim for that, and that's what we should be doing. So for you all also, don't be limited by the repertoire of interventions that are available. Don't be limited by that. Don't make it your box, something outside the box that you are going. And if there is a message from today's, grand round, I think the message is set your mind on that and look for it, and you will find it. I will tell you one or two examples of that from some of the work that we have done. So, when I embarked on my PhD, my supervisors told me, we have looked at everything that we can think of. The condition that I was researching was a condition called preeclampsia. You know preeclampsia, right? So they said, look at the pathophysiology, and you come up with your own genes and you study them. Lo and behold, I spent kind of 2 years looking at, I came up with my own genes and look at it. And then, lo and behold, one day, we sit down and we're doing all kinds of analysis to find some association. And then, nothing, I find no association with the diseased population, right? So I have also a control population of normal people, normal women and their babies. And then I do analysis on the normal women and their babies, because, with a kind of a last hunch kind of thing, I thought, okay, babies are small, so babies born to women with preeclampsia are small. Well, there's a gradient in the babies which are born to normal women. Shall we see whether we can, find out whether the gradient matches with the genetic variants? Do analysis, do and behold, you find that that is the case. So you find, so in that PhD work, I was able to find that there were genetic variants which women had, which were preferentially transmitted by the woman to babies who were small for gestational age. And then you go and you kind of replicate it in other populations and you find the same thing. So that on the pathophysiology of a condition which nobody had insight into. Then the student comes here and again, like I'm trying to destroy the myth, if I want to, that these things only happen in the West. A PhD student comes and we had, if you remember your preeclampsia is a disease of theories, right? That people are saying, okay, there can be a genetic component, there can be an immune component, there can be an infectious component, and all kinds of things. And why can't you prove that there was an infection during the time of placentation? Where if there was an infection, the infected organisms are dead, and it has been dead for 10 months, and you will only get to it at the end of 10 months. So in 2012, we have this fantastic new technology called next generation sequencing. So you can sequence anything. So my PhD student came and I said, okay, now we're working on preeclampsia. We'll work on, there is this theory that there's an infection component to preeclampsia. And let's see whether we can harvest placenta from women and extract material and sequence them for what we call a metagenome, looking at all the bacteria and see whether any one of these women have bacteria in this placenta which are supposed to be sterile. And lo and behold, it proved that there was a subset of women with preeclampsia whose placenta actually had bacteria in it, inside it. So these were the placenta were harvested in the theater at the time of a cesarean section and taken out. And that was the first paper in the world where next generation metagenomics was done on a placenta. And that is the most cited paper that we have from our group. So this kind of, novel things can be done here. It's just a matter of putting your mind into it and doing that work. Sky is the limit. Sky is the limit for you. So don't stop at the clinical work, but go beyond and explore the clinical, engage in that clinico-pathological exploration, and that will really take you places, and that will help you cure conditions. Finally, are there a lot of conditions out there to be cured? What do you think? Or everything that's out there to be cured has been cured or not? Well, the answer is if you look at all the non-communicable diseases, none of them have been cured. Right? But if you look at them, the data, there are more than 8,000 conditions. It may even be now hitting 10,000 conditions for which the molecular mechanism has been identified. But we have only interventions for about 500 of those pathways. It's not me telling that, it was the person who really kind of opened my eyes to this was Francis Collins, the guy who led the Human Genome Project about 10 years ago. Put a lot of people into one room, and I was also invited. They didn't have anybody from these low middle income countries, so they probably invited me. I was in genomic medicine. They put us in a room and put this up and said there are so many, all these molecular mechanisms have been identified, but we have only, interventions for 500 of those. Somebody has to start looking at the others. And that's what led to this organization called the Global Genomic Medicine Collaborative, which I chair these days. So that's the kind of potential that is there. So we need to look at these interventions and do a lot of things. And the final message that I have to you is the interventions are just not only coming from our system of medicine, but we are also from the traditional systems of medicine. There was a patient who we diagnosed here with a genetic condition called child syndrome, which results in skin abnormalities, skin loss, and all kind of stuff. So we sequenced the patient, found the variant, gave a diagnosis of child syndrome, and the patient went away. Parents took the patient away. 6 months after, the patient came. So this Western incurable disorder was cured by an Ayurvedic physician. So it was not a misdiagnosis because we have the gene, we have the mutation. It's published. This is a Google, you go to watch child syndrome and put my name on PubMed, it'll come. And it's okay. So we are in this fantastic, place where we can collaborate with these people also, and we should be making use of those opportunities. Focused collaboration between the other systems of medicine. So that's it for me. So my emphasis is the top part of this will get you through the finals. The bottom part of it will make you a true clinical scientist, and that's what you should be aiming for. Thank you very much.
Thank you, sir. Now, I hope that everyone had medicine, and moving forwards, we would really value your feedback by the QR code here. So let me see your, lift up your phones and fill the form. So while you fill the form, we'd just like to take a moment to thank those without. So first, I would really like to thank Dr. Praveen Weeratunga for his expert guidance of Grand Round Medicine, and to present a token of appreciation to Dr. Praveen Weeratunga, I'd like to invite on stage the Dean of the Faculty of Medicine, University of Colombo, Vidya Jyoti, Senior Professor Vajira H.W. Disanaik, University Colombo Clinical Society, Professor Saroj Jayasinghe. Thank you, sir. And a part of the vision of Grand Rounds is also to involve a student as the case presenter. And moving forwards, we would also like to recognize the contribution by the student. So next, I would like to invite the Senior Treasurer of the University Colombo Clinical Society, Dr. Nisha Rockwood, to present a certificate to our case presenter for Grand Rounds Medicine February, Ms. Tarushika Anjali. My pardon, Tarushi Anjalika. Thank you, madam. And I'd just like to take a moment to also thank the Dean of our faculty, who has always been a pillar of support with whatever event that we would like to organize. Our patron, Professor Saroj Jayasinghe, who is always ready with his valuable advice and inputs regarding the various projects, the continuing projects and the new projects as well. Dr. Nisha Rockwood, our Senior Treasurer, who is always there every step of the way from inception to execution. I'd also like to thank Dr. Sarit Ranavaka, former President of the Society, along with the other past members of our Society, who are always there with whatever help we want. And with regards to Grand Rounds today, I'd also like to thank Dinar for helping out with the live streaming, Vinuda, our photographer, Asni and Musni, who were the ushers for today, Manik Srivardhana for handling the token of appreciation, and all the other committee members who came here to show their support. And last but not least, I'd like to thank the audience, both our students as well as the external students.